I'd now like to call the chairpersons for the GIT session, please. Professors Ahmed Izzat, Professor Khalid Al-Husseini, Professor Muhammad Farouk, Professor Tamer Al-Nahas, Professor Ali Azmi, Professor Mahmoud Al-Mitini, Professor Muhammad Al-Basyouni, Professor Walid Arafat, Professor Hisham Al-Ghazali, Professor Muhammad Abdullah, and last, Professor Rasha Abdel Mutagalli. Please come to the stage for the GIT session. Thank you.
Good afternoon, everybody. It's my honor to present the GIT malignancy session. First of all, I would like to express my deep thanks and congratulations for my home and Shams University Faculty of Medicine Clinical Oncology Department for this great conference. And it's my honor too to present the first session. The first speaker in this session, Professor Ghassan Abu Alfa. He's going to talk about update in systemic treatment of cholangiocarcinoma.
Good afternoon, everybody, and I hope you hear me and you see me very well. First, I would like to second the chair's comments. Congratulations on a great meeting. It's really a great honor and pleasure to join you today. Sadly, as you know, this is what I could consider second home to come to Egypt, and sadly, because of the pandemic, we're not able to, but definitely will make the best out of it, having this session virtually. And again, congratulations on an incredible effort to do despite all what humanity is going through at this point in time. Also, I'd like to thank all the chairs for the warm invitation and warm welcome. I'm speaking to you from New York City, from Memorial Sloan Kettering Cancer Center, and I'm more than honored to give you an update in the systemic treatment of cholangiocarcinoma. These are my contacts. If you'd like to either copy what you need, or you can even take a picture of the QR code that will connect you directly with me. And I'm more than happy, as many of you know, Dr. Izzat and others, always happy to answer at any time in regard to any academic research or even medical care question. Please take what you need, and if not, Dr. Adunya from IRIS and the team have my contacts as well, and I'm sure they would be happy to share them with you. With this said, we'll start by bringing in epidemiology and staging. We'll talk about chemotherapy as an intervention for cholangiocarcinoma, targeted therapy, big item, and of course, we'll talk about checkpoint inhibitors as well. Ergot epidemiology, this is really how we understood the disease to begin with. If anything, the understanding that if the tumor is inside the liver, we call it intrahepatic cholangiocarcinoma. If it's outside the liver in the bile duct, still extrahepatic cholangiocarcinoma, and of course the gallbladder cancer. Now, the reason I present this, we all know this, but to really remember that anatomy was simply because this is how much we knew at that time. But I'm gonna bring an argument that probably a biologic perspective of how you do delineate the disease is definitely coming. If not, we already are applying it one way or the other. And this is a good example of what we published ourselves, and many other groups worldwide have done the same effort, where we're looking at the genetic alteration in regard to the tumor. And if anything, we have noticed the following. Some genetic alterations are applicable only to specific tumors, i.e., for example, intrahepatic cholangiocarcinoma versus gallbladder, etc. The other important component is that even within the same tumor, there is a certain mutual exclusivity that we proudly published for the first time at ASCO, and then we have it in CCR now in 2018, what we call MEGA, or mutual exclusivity of genetic alterations, i.e., if a tumor is actually having a mutation of IDH1, it's less likely, if not possible, to have FGFR2 fusion, and vice versa. And this is going to become very important for us as we delineate further the evaluation for treatment plans. With this kind of early and short epidemiology staging perspective, we'll start with chemotherapy. And of course, we all are applying the ABC02 study done by our colleagues in the UK, looking at gemcitabine plus cisplatin. that showed an improvement in survival compared to gemcitabine alone, 11.7 months for the gemcitabine cisplatin versus 8.1 months for the gemcitabine. We all got excited. At least we have a standard of care. We're using it. We've been applying it for a long while since it was published almost 12 years ago. And interestingly, despite that kind of like improved survival, we were a little bit intrigued by this progression-free survival, which is rather long, 8 months for the gemcitabine cisplatin. And here I would please warn you that in the UK, contrary to what we do in Egypt or even in the US, they scan less frequently. And remember, if you are not seeing a scan, you cannot assess for progression-free survival. And as such, you might, by default, kind of, misperceive a longer progression-free survival than it is. So please keep this in mind, because it's going to be important when we compare novel data that might say, wait a minute, how come I have great OS, but not the PFS is not as good as the ABC02? And this kind of like might explain at least some of those factors. There was a study that kind of shook us all in a positive way of triplet combination, cisplatin, gemcitabine, and nab-paclitaxel. And as you can imagine, this was rather pretty positive, showing an improvement in survival up to 18.8 months, please within the context of a phase 2 clinical trial. If anything, this is yet to be further evaluated as part of what's called the SWOG 1815 study, which already has completed accrual and we're waiting for the results. Now, many of you might ask, so NCCN guidelines write already gemcitabine cisplatin nab-paclitaxel as an option. Please remember one thing, NCCN are guidelines, they're not rules. Number two, your perception on how you evaluate this is going to be very important. Because a concept that's very important to talk about, which is the equipoise of novel positive data, but yet no confirmation of that data. How do we weigh this in? Of course, triplet combination showing improvement in outcome, but what is the impact, for example, in regard to toxicity? Because no doubt the adverse events from the triplet combination, you and I will agree that it's not going to be as subtle as it is in doublet. Let alone, for example, the tingling sensation. I would say, maybe a little bit in the winter time. I know the Nile River might cool off, and putting your hands in the Nile River and the relatively cold water is not going to be fun for somebody on cisplatin and nab-paclitaxel at the same time. And this is kind of to give you the perception that's needed to really look into in regard to toxicity. Regardless, I would say cautious recommendation in regard to if you would decide to use triplet combination, but definitely I would wait for the phase 3 clinical trial. The story did not stop there. If anything, the group from the UK did bring in ABC06 study looking into FOLFOX as second line. And this kind of was a little bit complicated to really understand. If anything, I'm showing on purpose, this is already published, but I'm showing the abstract because at that time, to remind you, there was discussion, who are those patients? Did they get cisplatin and progressed on cisplatin? Did they get cisplatin, did not tolerate cisplatin? Or did get a little bit of cisplatin and moved on to FOLFOX anyway? And we have to really put all this in perspective before we embark onto the FOLFOX therapy. To our good luck, there's a new study that was published just lately at ASCO a few months ago that looked into liposomal irinotecan plus 5-FU, what they called the NIFSI study. This was done by our colleagues in Korea. I confer here that I'm part of the team. We were not part of the study, but we were giving all the guidance needed. And if anything, we showed with the combination of Naliri plus 5-fluoroquinolone an improvement in survival and progression-free survival. And this was a small randomized phase 2 study that brought in a PFS of 7.1 months, as you can see over here, for the Naliri versus 1.4 for the FU-leucovorin. So again, this might at least give us a wealth of information got to potential new therapies, and of course, leave it to your judgment in regard to the options that you would like to use. And the survival, by the way, was also a positive outcome, despite the phase 2 study, as you see, 8.6 months versus 5.5 for the 5-fluoroquinolone. So this is a chemotherapy, but the good news about, if you remember, as we spoke in the epidemiology of the disease, to talk about targeted therapy. We proudly, and just literally this week, you probably have seen the article already, we presented the latest update on the final overall survival of the mutated IDH1 ivosidenib, anti-IDH1 ivosidenib therapy versus placebo. And as you can see over here, there was clearly an improvement in survival. Please do understand that this study did allow crossover, so we had to do certain instrumentation statistically to prove the survival improvement. As you can see in the dark blue, this is the ivosidenib median survival 10.3 months. The placebo, independent of the crossover, in other words, just as is in the study, was 7.5 months. But if we were to consider placebo and consider patient never crossed over, which is a random rank preserving statistical tool, the RPSFT, you can see that the survival is 5.1 months. So please, if you were to look at that data, I urge you to look at the ivosidenib 10.3 months versus placebo 5.1 months and see the survival improvement. Which, by the way, was further supported by, again, from the article this week, a long extension in regard to the duration of response. And if anything, the drug hopefully is already available in Egypt. But by all means, if you're patient to have mutated IDH1 as second-line therapy, this is a totally applicable treatment. And also proudly, the FDA 2 weeks ago, this is all good news and brand new news, already approved the drug in second-line treatment for mutated IDH1 cholangiocarcinoma. A word of caution, we don't not yet know more about, but interestingly, a question that arises every now and then, do we need to re-biopsy patients? We're not sure, but we reported ourselves from Memorial Sloan Kettering, a patient who was having an IDH1 mutation that reversed to IDH2 mutation. How would you really assess that? I think lack of response might all finally force us to do another biopsy, but we just have to wait and see. But at least we know that these tumors are under pressure, and definitely they're gonna try to bypass the blockade that you're causing, for example, by ivosidenib or the likes. We'll switch on to another mutation, which I already brought up in the beginning, which is FGFR2, which is a fusion of two genes together. This is, if you recall, infigratinib, the first one we reported. Again, literally, this is just published as well in Lancet Gastroenterology Hepatology this week. Proudly we were part of, and the survival was 12.2 months. This is infigratinib, already approved. And on top of that, we also led another effort of pemigatinib, another anti-FGFR2 fusion rearrangement. This was published also a little bit earlier, was also already approved, and we proudly presented it at ESMO, if you recall, in 2019. And as you can see over here, it shows a drastic improvement in survival for the patients with response up to 30 months, which interestingly translated in this incredible response, as you can see over here, including even some complete responses with a response rate of 35%. I would say both drugs are okay. I wouldn't necessarily try to compare one versus the other. You can try to kind of dissect the data and say that, you know, pemigatinib has a greater response, improvement in survival. But of course, I leave it up to your judgment. And I would not necessarily say that one is going to be better than the other at this point in time. Interestingly, though, another thing, same way I introduced the IDH1 that turned into IDH2, no doubt that also genetic alteration can occur under pressure by therapy. This is in a study that was done that shows very clearly that an FGFR2 fusion will change from a certain gatekeeper fusion like the V564F to another fusion. And this way, you wonder if you are treating the tumor correctly. Interestingly, can we sequence the anti-FGFR2? A question that I'm sure you come all the time with or you are asked about. Well, we have some thoughts on that because interestingly, futibatinib, another irreversible FGF1, 2, 3, 4 study, which again was published this week. I can't believe it, like 3 drugs with publications this week related to cholangiocarcinoma. As you can see here, it has great responses And it appears to be that there's certain kind of, add-on value to the futibatinib that might kind of serve as a bypass for a prior resistance to pemigatinib and infigratinib. Something to, again, think about that, yes, maybe, I can't say that for sure, but maybe, yes, by jumping from one of the anti-FGFR2 to another could be valuable. Switching to another mutation totally, this is very rare. BRAF V600E, which we know quite a bit about it in colorectal cancer, can occur in biliary tract cancer. This is nice work that showed, yes, it can get great response. And I was asked at the time it was presented in ESMO, would you, for example, consider that therapy as first line? I would say yes, why not? This is incredible responses and limited other choices besides the chemotherapy, and same time the drugs are available. It's something to consider in case of BRAF V600E. Please remember, the potential for this is going to be less than 5%, but at least still worth to be checking on. If anything, a very important message over here, all of us, please, it's very important, all of us are required to do genetic testing on all the patients with cholangiocarcinoma. I would do it as early as possible rather than late. Even as the patient coming for a first consultation, this should be already done. There are a lot of venues, I don't know which one you use, among which including the impact testing that we do at Memorial Sloan Kettering, and we probably have done it already with patients who are international. Patients can send their material to New York, and same time we just get nail clips to do the comparator to normal testing, and we can provide the report in no time. And I know that probably some patients already have done it from Egypt through Memorial Sloan Kettering, and happy to help with that. We'll jump on to the last point so we can wrap it up. No question, we all know about the MSI high. Again, please, I put it in a green arrow. It's not that common in regard to cholangiocarcinoma. Would I check for it? Of course I would. But would it be really that common? Not necessarily so compared, for example, to endometrial cancers. And on top of that, what about the anti-PD-1 in regard to application in cholangiocarcinoma and biliary cancer? Yes, a lot of nice work. This is from Dr. Kemp that was presented at ASCO 2 years ago and published last year. Yes, some nice response and survival regarding within the limitation of a phase 2 study. We have the GemCis plus durvalumab, great work that came out of Korea by Dr. O and team, and we're proud to kind of be part of this continued collaboration in that regard. And of course, we have also the GemCis plus durvalumab. Now, what about combination with chemotherapy? Again, nice work that need yet to be further validated in regard to value and application in regard to standard of care therapy. Nonetheless, the numbers are promising. It's nice to see the number of survival jumping from 8 to 11 and now up to 20 months. And this again for Nivo-Ipi, I would say durvalumab we kind of a little bit more excited about because we always are worried about the Ipi toxicity because of the repeated treatments, while with the tremelimumab, usually we give one dose only of the anti-CTLA-4. And the last one that you just published as well is the atezolizumab plus cobimetinib. I would say that, as you can see, independent of what kind of tumor it is, extrahepatic, intrahepatic, or gallbladder cancer, it will probably be applicable. But I would say that the PFS was rather relatively limited. I would say this kind of combination needs to be further delineated before we push it any further. And as such, I summarize, it's a new era in the treatment of cholangiocarcinoma. The most critical place is very important to do the genetic testing. You need to do next generation sequencing on whatever platform you want. As I mentioned, we have the Memorial platform, always happy to help you if need be. We spoke about mutual exclusivity of genetic alterations, which happen most of the time. Actionable genetic alterations, we spoke about the ones of IDH1, FGFR2, and the BRAF V600E. And of course, we also talk about the resistance and potential chaotic phenomenon that can evolve from one of the FGFR2 fusion to another. And ultimately, we spoke about checkpoint inhibitors, even though this is still, the best I can say, still under study. I will pause here. I thank you again for listening. And I know if the chairs would like me to answer any questions, more than happy to. I'm stopping sharing my screen. Thank you again.
Thank you, Professor Sam, for this fruitful presentation, and you can open the floor for I think 1 or 2 questions because we have tight time, if there is any.
Yes, hello, Dr. Ghassan. I have a question for you. Due to the unavailability of nab-paclitaxel in Egypt, would you consider its substitution by paclitaxel?
That's an excellent question. I'm so happy you brought it up. Actually, believe it or not, it appears to be that there could be even some shortage on nab-paclitaxel, even in the US at this point in time. And if anything, yes, paclitaxel could be an option. But however, before I'm answering the question directly on that, but however, I'm a little bit nerved up about still using gemcis and nab-paclitaxel. I gave you the argument that, yes, data is exciting, but take my word, I've been part of that study. The toxicity that you can see from the triplet combination is not something what you wish for your patients. So I want to kind of make sure that we strategize, not about I want response right now. I want to rather strategize, especially with the wealth of the different options that we have, about what we can do is step number 1, step number 2, 3, 4, and 5. And as such, not always react in a way, I have a problem, I want to fix it right now and move on. I would like to see how can I keep the patient going to get the other opportunities later on.
I think we have no question anymore. Thank you, Professor Ghassan, for your time, and we really appreciate your presence with us. Thank you a lot.
Oh, thank you so much again, and congratulations one more time, and looking forward to see you in person, inshallah.
Now, let me introduce our second speaker, Dr. Mark Peters from Antwerp, Belgium. His talk will be about the proper sequencing of chemotherapy lines in metastatic colorectal cancer.
Many thanks for this invitation. So my name is Mark Peters, and I try to share my slides. Can you see my slides?
Yes, yes.
Yes. So it's an absolute pleasure to share with you my insights on, and I cannot change because this is not good. 1 minute. Do you see the slides correctly?
No? Yes,
No. Wait a
it's
minute.
now available, yes.
I'm gonna try to resolve the problem. And now?
Yes.
Okay.
It's okay now.
So it's an absolute pleasure, and thank you very much for this kind invitation to share with you my insights on the best sequence for first-line treatment of metastatic colorectal cancer. It's on behalf of my colleagues Hans Prenen and Timon van Damme, who are sharing the GI oncology unit in Antwerp University Hospital. So these are my disclosures. So I want to go back some years ago. At that moment, this patient presented, the age of 53, no major comorbidity, second degree relative with colon cancer at the age of 50, presenting with some atypical abdominal symptoms, some intestinal blood loss, at a certain moment also increasing fatigue, constipation, fever, and weight loss, more than 5 kilograms over the last 2 months. And all these symptoms occurred during a period of 9 months. At that moment, these were the lab values, and you clearly see an increased LDH, also an increased, dramatically increased CA level of 14,507. And diagnosis was performed, colonoscopy showed a tumor in the cecal region. Biopsies were taken, moderately differentiated adenocarcinoma. Please remember at that time, we performed in routine the RAS status. This was a RAS wild type tumor, BRAF mutated. And based on that, normally we took a decision. What were the drugs that we had available at that time? This was mostly a combination, especially if you have seen the scans, this was fully metastatic patients where no options for surgery of the metastatic lesions could be proposed to the patient. So we went to systemic treatment, and you clearly see that we had chemotherapy, 5-FU based, in association with irinotecan or oxaliplatin. We had at that moment anti-VEGF treatment available, especially bevacizumab in that first-line setting. And knowing that this patient, and you can debate because this is right-sided tumor, but the tumor was RAS wild type, at that moment you could think on a combination with anti-GVAR antibodies. But we have seen over the years, and the reason why I'm showing this slide is because at the moment that you want to decide which type of treatment you want to give to your patient, you have to know what is your strategy. And the strategy over the times changed also. We had the introduction, as I showed you in the previous slides, of targeted therapy. You combine this with chemotherapy, but also in certain patients, there was an intervention. Intervention could be surgery, could be also spheres, could also be radiofrequency ablation. And in certain patients, you had maintenance treatment or treatment holidays. So all these factors, all these therapeutic strategies, you need to take into account to decide which type of treatment that you propose to your patient. There is another important issue is that the clinical presentation of your patients changed over the years. More factors are influencing your decision. First of all, is this a patient presenting with synchronous or metachronous tumor? The location of the primary tumor, we have seen the impact on prognosis, but also as a predictive factor, left versus right. Is this patient having oligometastatic disease or multimetastatic disease? The location of the metastasis, for example, if you have a patient with peritoneal metastasis, the strategy and the decision on a given treatment is totally different. And the molecular profiling over the years, as I showed you 5 years ago, mostly we performed RAS and BRAF status, but in a few minutes I will show you that more and more molecular markers might play a role in the decision tree. And not to forget the status of the patients, performance status, but also especially the fact that this is mostly an older age population, the comorbidity of the patient. I don't want to go into detail because this was discussed several times, the impact of having a tumor, primary tumor on the right or on the left side, the fact that the mechanism of pathogenesis is probably different on the right versus the left side, and also the molecular profile is different on the right versus the left side. So what is the decision pillars that we have today? You have the clinical presentation, performance status, comorbidity, the fact that there is a primary in place, yes or no, the sightness. You have molecular profiling, RAS, BRAF, and today more and more MSI testing is performed. In some cases, HER2 status is determined, and the imaging pillar, thoracic and abdominal CT scan, and especially when you think about surgery, MRI, in addition with PET scan, might be performed to have a good multidisciplinary team discussion with pathologists, radiologists, surgeons, interventional radiologists, and oncologists to decide what is the strategy. It's not only about efficacy, but please remember the slide that 5-FU is still the base of our treatment regimens that we offer to the patients. We have to be sure that it's safe to give 5-FU. And in Europe, the guideline today is to test for DPD deficiency. The fact that you have a DPD deficiency might have an impact on the toxicity. This is related to dose reducing, and in some cases it is impossible to give 5-FU because of a complete DPD deficiency, which has a high chance of having high toxicity and even death when you treat these patients. Coming back to the molecular profiling, this is the distribution. You see that most of the tumors are currently, based on the methodology that we are using, are RAS mutant. A fraction of 40-45% is RAS wild type, but see that there are other molecular alterations which might play a role in your decision. For example, BRAF, but also MET amplification and HER2 amplification might play a role. So let's focus on the patient that I presented. There was a BRAF mutation. The question is, what is the best strategy in first line? We have seen these retrospective data of the Italian group published in the Lancet Oncology, where there is clearly a difference if you look to the BRAF mutated population in red between the ones that received doublet plus bevacizumab in comparison with the triplet plus bevacizumab, still doing worse if you compare it with the RAS group, which are in green and in light blue. These were small groups of patients, these were retrospective data, so we waited for prospective evaluation of the strategies that were proposed. And this was presented at latest ASCO, where patients with a BRAF V600 mutation, because this is important, this is the most relevant mutation, were randomized in a 2-to-1 setting between the triplet chemotherapy plus cetuximab versus the triplet chemotherapy plus bevacizumab going to maintenance. The idea was to obtain a higher response with cetuximab in comparison with bevacizumab, a relative improvement of more than 37%. Looking to the results, you see there is no big difference between the cetuximab arm and the bevacizumab. The opposite is even true. You see that the benefit on PFS is in favor of the bevacizumab arm, and even overall survival has a tendency in favor of the bevacizumab arm. This is a phase 2 study, but the results are somewhat contradicting the experience that we had in the clinic. We are waiting the results of the Breakwater study based on the philosophy that probably targeting the pathway at different levels might have a better impact than treating these patients with chemotherapy. And this is based, of course, on the Beacon study results where encorafenib, bimitinib, and cetuximab were combined, or the doublet, and you see better response in comparison, or better outcome in comparison with the standard chemotherapy and cetuximab. There was also a remarkable study, and we don't have a clear explanation, but this might have still again an impact on your decision tree. This was an ad hoc analysis based on the Beacon study, where they looked for the impact of bevacizumab on the doublet combination, the triplet combination, and the control. And if you look in the middle, the triplet combination, where the patient received in frontline bevacizumab, it's clear that the group that had bevacizumab was doing worse than the group that didn't have bevacizumab in the frontline setting. This was only true for the triplet group, but not for the doublet, as you see on the top of this slide in the red curves. So coming back to your patients, today we would do also Msi staining, and you clearly see that here this patient have two types of molecular alteration, BRAF mutated and MSI high. So at that moment, the data of the Keynote 177 come in, well known and published very recently in the New England, where you clearly see that the impact of frontline pembrolizumab in comparison with chemotherapy is in favor of the immunotherapy arm. There is one, if you think that you have to focus on, if you look to the KRAS or NRAS group, the all white type, there is clearly favoring the pembrolizumab arm. If it is a mutated tumor, there is a tendency that the chemotherapy is doing better, but this needs to be confirmed in later studies. So the question is, what would we do if at a certain moment the breakthrough study is positive, you have an BRAF mutated tumor, MSI high, would you start with immune therapy, knowing that there is a fraction of patients that are not responding? Or would you go immediately for the doublet or the triplet targeted combination with a higher response probably than the immune therapy? So this is still an open question. Also, the profile of side effects might have an impact on your decision. We know that immune therapy has some specific side effects. For example, in this study, colitis, pneumonitis were seen in a fraction of patients. In the majority, well controlled after some measures on the treatment. It's becoming even more complex, but because today we know that other amplifications or mutations might play a role. One of them is HER2. Most of these data are in later line, where we have an impact on the response of 35% if we use doublet. If we look to the newer data, where HER2 amplified metastatic colorectal cancer is treated with a conjugate drug, you see a response of 45%. There are studies going on in this population in earlier lines, and this might change our strategy in the future if these data are confirmed, knowing that also such a drug has some side effects which might impact your decision. Other important, very small fraction of patients, but we have seen at ESMO interesting confirming data on KRAS G12C targeted drugs. This is the first one, AMG 510, where there is a clear stabilization of the disease in later lines, and it might be in the future that this type of alterations might guide your decision to treat your patient with these drugs in the future in monotherapy or in combination with chemotherapy. NTRK fusions, small number of patients, but if you have the detection of such a fusion in colon cancer, also their responses are very high with larotrectinib or with entrectinib, and always you have to think whether you can start with this drug or start with chemotherapy and then switch to these type of drugs. So coming to my slides from some minutes ago, so the treatment options that we have available of our patients is increasing over the years. You had the ones with chemotherapy, you had also the drugs targeting VEGF and anti-GVR. You have immune therapy in this MSI high patient population, but also trastuzumab, encorafenib, binetinib are part of the treatment strategy, not necessarily immediately in front line, but this can change in the coming months. But especially thinking about the strategy is important. Treatment strategy. We talked about maintenance. Maintenance part is part of our first line. And this is a study with panitumumab where FOLFOX treatment was started in combination with panitumumab. 5-FU leucovorin plus panitumumab was compared with 5-FU leucovorin in the maintenance strategy. And it's clearly that the combination with the antibody is doing better than the chemotherapy alone. We challenge not necessarily impacting our first line, but again, it's important to think about that because based on circulating tumor DNA, switching from one line to another might guide your decision in the frontline setting. For example, if you start a patient with anti-GFR plus chemotherapy, you have an anti-GFR free period, and then you test circulating tumor DNA, whether these tumors are still RAS-BRAF wild type, you can obtain a high response rate with the re-challenge with anti-GFR treatment. So coming back to my slides, it's clear that the pillars on which we take the decision in frontline are increasingly populated with different factors that influence our multidisciplinary team discussion. So it's becoming much more complex than before. And ultimately, you come to this type of strategy where the based on these factors, you make the decision in the different groups presenting with metastatic colorectal cancer. Your first line, of course, is determining the next lines. When you use some drugs, it's very difficult to reuse them in second line or in third line, with the exception if you have really an evidence-based evaluation. And this is probably the introduction of circulating tumor DNA in our strategy. So, in conclusion, you still have a very heterogeneous population with different open questions. For example, how to test all these tumor samples, all these liquid biopsies, and to generate all these factors. These are important in the frontline decision making. What is the optimal sequence? For example, coming back to our patient, BRAF mutated MSI high, which type of treatment will you start in a given patient if you have two different options? Which type of combinations? And of course, the sequence with different molecular alterations. So what is the take-home message? Frontline treatment of metastatic colorectal cancer is clearly more complex than 5-6 years ago. You have the increasing number of subgroups with specific treatment strategies. There is clearly the reinforcement of the multidisciplinary team decision, not only in frontline, but it's a very dynamic process, and evaluation is necessary to guide our decision. And for me, even for me, it's clear that with all these subgroups, more options become available, but the complexity is increasing over time. I thank you very much, and I'm absolutely open for questions.
Let me thank you, Dr. Mark, for your informative talk, and we have 5 minutes for any question from the audience. Any question? So I have a question for you. Dr. Mark, would you expand the indications for checkpoint inhibitors to be not only for macrosatellite instability high, but also to include the HER2 overexpression and the total mutational burden as the situation in gastric and esophageal cancer?
Yeah, I think it's an excellent question, and I must say I have a problem with all these classifications for the moment. If you look, for example, to the data in esophageal and gastric cancer, you see sometimes CPS scoring, sometimes you see mutational burden, CPS scoring less than 1, less than 5, less than 10. So it's very difficult to make a clear statement. For the moment in metastatic colorectal cancer, the driving to decide whether you go for immune therapy in a given patient is the MSI status in most of the countries. And we don't take other measures to guide our decision whether we treat these patients. So the difficulty there is that we need more biomarkers to try to inform us which fraction will not respond, because you have seen the curve. There is 15-20% of the population that are not responding, but we cannot detect them up front for the moment based on the analysis that we are performing. And I don't believe that CPS scoring or mutational burden is giving the answer today.
In colorectal tumors overexpressing the HER2, you mentioned it is about 2 to 3%. I think it is more than this in literature about.
It's correct. No, it's more than the HER2 overexpression or amplification is more than 2 to 3%. It's between 20 and 25%. So the other mutations, for example, the G12C, that is between 2 and 3%, and also NTRK is around 2 to 3%. But HER2 is more frequent than all the other.
And in those patients, would you prefer a dual blockade for HER2 or a single blockade?
I think based on the literature that we have available for the moment, the doublet blocking is doing better than the single blocking. Although you have seen the interesting data with the conjugate, where you combine two molecules, where you obtain high responses, which are comparable with the responses that you obtained with the doublet. So probably in the future we will move to that new drug compounds that we have available, but in the earlier lines, first and second line, we have to wait the results. There is a flip side. The pneumonitis is an important side effect that you see with this new conjugate, and that you need to take into account as a risk factor to treat these patients with these new drugs. But I believe that in the future we will go for one compound other than the ones that we are using, such as trastuzumab and lapatinib. If we want to use them, it's better to use the combination.
Okay, thank you very much. There's a question, please.
You have emphasized the role of unneeded toxicity of treatment, like the slide of DBD deficiency. Is there any idea or any criteria when to stop systemic treatment in the maintenance phase upon a stable disease for a period or something like that?
Yeah, I think it's an excellent question. Maintenance and even treatment holiday is part of our daily practice. In most of the studies, they are using a fixed number of cycles to decide whether you go to maintenance or to treatment holidays in certain patients. I must say that in my own practice, if I see, for example, after 4 months a good response or a good stabilization of the disease, and the patient, the balance of the quality of life is not good at that moment, I mostly decide to downgrade the regimen and go, for example, to 5-FU plus bevacizumab or 5-FU plus anti-Jafar in this setting, and then see what is happening. And in some patients, I stop the treatment, and after 2 months, I evaluate. And sometimes you can have a break of even 4 to 6 months without any risk of rapid progression of the disease. I hope that in the future, the information that we get out of circulating tumor DNA might guide better our decision whether we can stop or whether we need to continue intensive combination, yes or no. Because there are some data, if you have no circulating tumor DNA anymore after a treatment period, the chance of rapid progresses is very low in comparison with them that still show some circulating tumor DNA. So for the moment, it's more a clinical decision, but hopefully in the future, in the near future, we have the guidance on circulating tumor DNA to help to decide or stop and go strategy or stop and maintenance therapy. I don't stop the treatment or I don't go to maintenance before 3 to 4 months. I think if you stop after 2 months or go to maintenance after 2 months, it's too early in the majority of patients.
Okay, thank you very much.
And now it is time for next speaker, Professor Dr. Ghada Rifat.
Thank you very much.
Thank you. Dr. Ghada Rifat, Professor of Clinical Oncology at Shamsi University. Her main interest in GI, malignancy, and gyna oncology. Dr. Ghada will present her insights about the incidence of colorectal cancer in young adults.
Thank you so much, Doctor. Thanks so much, Professor Dr. Khalid Hussein. Before everything, thanks so much for inviting me. Thanks for the organizing committee to give me this chance. I love this lecture very much. And I have the honor to present it in front of my professors, Dr. Ali, Dr. Ahmed, and Dr. Khalid, Dr. Ihab, and everyone. The rising of colorectal cancer incidence in younger population and its implication. Actually, I'm giving this lecture to all my young patients, all our young patients with colorectal cancer. I always feel that they are little sisters and brothers. What is the young? It is different from country to country. Some use the cutoff of 40 or 50 or maybe 45. The adolescent and the young oncology group take the cut point of 29. But actually, we are using now the 45 cutoff point before we use the 50, because it is the cut point after which we say that it is adult and they can enter the screening program. These are photos for persons I don't know, but I think in the memory of every one of us are same photos for our patients, for those who are living or the souls of who died. The incidence was in the beginning of this century was also in the US. They said that it is from 2 to 10% only. The same country with recent data now in 2020 say that it reaches to more than 25%. And in Egypt, the publication in Egypt say it is exceeding the 38%, which is younger than 40, by the way, not 50. So there is initial misdiagnosis. There was diagnosis at later stage, and we'll see now that they are actually diagnosed late. The symptoms were ignored or delayed for some point or another, or misdiagnosed from the very beginning. This SEER data that I think is a nightmare. The study was in 2017, and this was a model for the coming years. So that there are more than 490,000 people aged 20 and older diagnosed with colon and rectal cancer from year 1974 to 2013. The problem is it is coming to increase, and that they predict that the rectal cancer incidence rate among adults in their 20s have risen more sharply, and that from 2010 to 2030, they performed like a predictive model and suggesting that the trends are persistent and they are more coming to increase, that the incidence of colon cancer and rectal and rectosigmoid would rise by 90 and 124%. Just like to imagine that the rectal cancers will increase in the age from 20 to 34 years of age by 124%. In the coming years to 2030. And this is another analysis that was pointed on the patients with resource-constrained countries, not only the US or the modern European countries. This is an Egyptian data by the dear Professor Dr. Ahmed Abdelaziz, who conducted a 7-year review, and it mentioned that about 38% of tumors occurred in the patients less than 40, but actually it didn't reach the exact etiology. There was no bilharzises, there was no genetic known syndromes, and also there was no adenomas. The adenomas in this age was rare, directing our attention all that this is a completely unique disease. This is data from our oncology department, the clinical oncology department in Ain Shams, and I was honored to be a part of it. And there was statistically significant difference in the pathological types. There was more mucinous cancer, more signet ring, more advanced disease. Does the young colorectal cancer patients have unique characteristics? Yes, sure. It's driven by the distal colon, especially the rectal, which is the opposite of the most common syndrome, which is the human non-polyposis syndrome, which is common in the right side. And we will see also the genetics will be different from the genetic known now. So it is from distal colon, from the rectum, it's mucinous and poorly differentiated signet ring, and advanced stage at diagnosis. From the majority of the publications, it is more T3 and T4, it is more stage 3 and stage 4. It's some spotlight on the genetics. The most of them are microsatellite stable. There was little lower frequencies of microsatellite instability. There is high frequency of pole mutation and TP53 mutation. The prognosis is contradictory. Some studies say that the early stages, stage 1 and 2, is better in the younger population in the young, but it is worse in 3 and 4. But actually, most of the studies, the recent studies, 2020 and 2021, is coming to an amazing conclusion that the young patient, although they carry a worse histology, a poor prognostic factors, advanced stages, they are having better survival than the older patients, more than 65 in age. What about the etiology? If we find the etiology, we can maybe improve our screening programs. We can reach causes that are reversible. We will see now. It is a combination of genetic, behavioral, and environmental factors. Is it hereditary or it is familial? Is there is known or unknown genetic sequencing or causes causing this increase in the young population? About 75 or more of the patients does not have any hereditary known syndromes or any other family history. We come to the environmental factors, and I like to start with the human papillomavirus because there was 2 important studies and meta-analysis in 213 and 214 focusing on the human papillomavirus and its relation to the young population of colorectal cancer, and it found about 6 and 10 folds in the 2 meta-analyses more in the human papillomavirus in colorectal cancer who are those negative to the human papillomavirus. And this study in 2014 focused on the high prevalence of the human papillomavirus in some areas in the world, especially the South America and Asia, and finally the Middle East. Is there a role of the pollution in the young colorectal cancer? Yes. The chlorinated water, the dumping sites of industrial wastes with subsequent soil and water pollution, pesticide pollution, and occupational exposures have a role and have a hand in this disease. This is a study in 2010. It's coming from Egypt, lifestyle and occupational and reproductive factors and the risk of colorectal cancer, and they found that the patients who are more likely to eat directly from the field without washing the vegetables, which is more contaminated with the pesticides, are younger in population, which is a very important point we have to focus on. Then the occupational exposure. Yes, there is occupational exposure, and some studies focused on the working in leather, basic metals, plastic, and rubber manufacturing. Very important point to mention that chlorinated water is now in very recent publications are confirmed to be a part of the colorectal cancer etiology. Are there known factors present? Of course. We all know that inflammatory bowel disease, vitamin D deficiency, lack of exercise, consumption of high fat, more red meat and processed meat, alcohol, smoking, and diabetes are all known risk factors of colorectal cancer. But is it more and more in the young population, younger than 40 or 45 years? Maybe. Increased body fatness in the early life, independent of adult obesity, can be a risk factor in the colorectal cancer in women. This is another point we have to focus on and highlight it, the use of the antibiotics in the late 1970s and 1980s have a role. Yes, we found that it has a hand in the young colorectal cancer etiology. Changing the microbiome by changing the diet, by pollution, and by the use of antibiotics can change the diversity of the microbiome, the normal microbiota of the intestine, and can change the benign lesions to malignant lesions, and especially in the rectum, which is more common in the young population. What is our role here? Our role is to increase the awareness of the early onset colorectal cancer. We have to identify all possible risk factors, to take every point in the risk factors that can contribute to early onset colorectal cancer and investigate it thoroughly. We can develop a targeted preventive and early detection strategies for the younger adult with higher risk. Another point I missed to say that the treatment of the younger colorectal cancer was compared young versus old in the intensity. Does the patients in young colorectal cancer patients, when I give them intensive treatment or more intensive treatment, more extensive surgery or more targeted or chemotherapy, does this attitude will change in the outcome of the patients? The answer is no. What shall we do? We can increase the awareness in the normal population and in our population, in the medical population, in the doctors. Even the doctors which are not in the oncology or in the surgical oncology field, because this is, it should be a normal practice that the warning signs, the bleeding per rectum in a 20 years old patient does not mean always that it is piles. It should be examined thoroughly and should be directed rightly. Thank you very much.
Thank you, Professor Rada, for this rapid awareness about CRC in young. And now it is time for questions, if any.
Thank you, Dr. Rada, for this nice presentation, as usual. I have a lot of presentation before. I enjoyed it. But I have a question. You just mentioned the young people have maybe better survivors than elders.
Yes.
That's due to what? Due to the tolerability and the fitness of the patient or the tumor response to many lines. Because I think we have in our unit in the Demirdash,
yes,
we have many teenagers patients.
Yes,
as far
actually,
as I remember.
yes.
So it's I didn't notice the response for such patients was better than elders.
They are really, thank you for this question, sir. It's really, they are really doing better. They are really can withstand multiple lines. They are really having no major comorbidities. And many of them are not obese or having any factor that hinders the performance status or may decrease their performance status, so they
Thank you, Rada.
Thank you, Rada. Do you recommend or do you voice to lower the limit, the age limit, to start screening for CRC in Egypt at least?
Yes, sir. I think it can be 45, not 50, but less than that, we have to pick up the high-risk population, maybe the smokers, maybe the known risk factors that the inflammatory bowel disease have its own, and the known hereditary disease has its own guidelines to be less than 50 or 45. But less than that, we have to ensure that there is risk versus benefit, that there is a financial and social benefit coming from decreasing this age.
Thank you.
Thank you for you all. Here we come to the end of our session. I hope all the best for you and for your successful activities, inshallah.
It's my pleasure to introduce the second speaker. The next speaker, Professor Vogel. He's going to talk about ION-HCC, the new killings of blood.
Okay. Yeah, thank you. Thank you very much for the invitation. It's really a great pleasure to be with you. And I would like to discuss with you the role of immunotherapy in HCC. And I think you already have started the discussion a little bit. I mean, we have seen the data for the TKIs, and the question is, what is exactly the place of immunotherapy in HCC? So this is the latest update of the ESMO guideline, and I think it nicely summarizes where we are at the moment. We do have a lot of options available for sequential therapy, and as you have just discussed, we do not really have good phase 3 evidence for the use of any TKI after atezo-bev. Nevertheless, in our ESMO guideline committee, we have strongly recommended to apply sequential therapy, and of course it always depends on local reimbursement, what you can use. But at the moment, we do not have any evidence that any of the TKIs tested in first or second line would not be effective after atezo-bev. But of course, in a perfect world, we would like to see phase 3 clinical evidence. But with the old drugs, most likely we will do not see these questions, as also highlighted by Richard Finn. But I think we will see other trials at the moment. As you all know, we have the new IMRACE study 251, which looks at the efficacy of atezo with lenvatinib or sorafenib after failure of atezo-bev. And I think we will see new combinations, and personally I think combinations will be the future, both in first and second line, also here after atezo-bev. So we just need to be patient, and then we will get more clinical trials. So in respect to overall survival, I think it's very clear that we have made an improvement over the years, which is most likely not only due to the drugs we are testing, but maybe also a little bit due to patient selection and the opportunity of sequential therapy. And I think also because our target population is a little bit changing, we do see now more patients with ASH and NASH, fatty liver disease, and most patients with viral hepatitis B and C are now treated. I mean, hepatitis C patients, at least in many countries, are getting the new DIAs, and so we have patients that are cured from the hepatitis C and maybe have even less fibrosis compared to those patients we have seen in the past. And with hepatitis B, we all know we would use the antiviral treatment to control viral replication. So, I mean, there are different factors that come into account here. So where do we stand with immunotherapy? As you all know, for Nivo and Pembro, the phase 3 studies were unfortunately negative, despite some very promising and interesting phase 2 data. Does it mean that the negative trial that there's no activity? I do not think so. If you look at survival data here for Nivo, I think they were extremely promising, and specifically when you compare to the data of atezo-bev, I mean, it's really getting close, 16 months compared to 14 months, which was very long here for sorafenib. Nevertheless, the primary endpoint was not reached. Negative trial, no approval by EMA. It is a different story by FDA. Here we have still an approval for Nivo-Ipi and also Pembro in HCC. Since the trial was negative, the question, of course, was, are there any subgroups that might derive a benefit? And one target, of course, or one potential biomarker, of course, was the receptor PD-L1. But as you can see here, with a positive detection of PD-L1, we cannot select patients that would have a specific benefit for mono checkpoint inhibition. There's some data suggesting that the response rate and PFS might be a little bit better, but it does not translate in a longer survival, so it's not suitable for selection of patients. In respect to liver function, I think this is a very important point, and for me as a hepatologist, something I would like to discuss a little bit more in detail with you later on. But first of all, here, when you look at the changes in mean ILV and Child-Pugh score with lenvatinib and sorafenib, you can see that specifically with the checkpoint inhibitor, liver function is clearly maintained which I think is really critically important to apply sequential therapy. So in second line, unfortunately, also we have a negative study, the Keynote 240 study. Again, very promising phase 2 data and promising phase 3 data. Response rate of up to 20% median overall survival, as long as we have never seen it before in a second line study. Again, here the company was, I think, maybe a little bit too aggressive in their aims. So despite a p-value for overall survival of 0.02, this was not sufficient to reach the predefined criteria for statistical significance, and therefore, unfortunately, also negative study, no approval by EMA. So since we do not have seen sufficient efficacy for the monotherapy, we do not have a good biomarker. Therefore, the question is, can we increase efficacy by combining different drugs? And the VEGF pathway, I think, is highly interesting, not only because HCC is a highly vascularized tumor and we can benefit from any anti-angiogenic treatment, but also this pathway is important for the immune environment, and we have seen preclinical data showing that by inhibiting the VEGF receptor pathway, we can decrease immunosuppressive cells and we can increase or promote maturation of dendritic cells. So there was a clear rationale to combine bevacizumab with atezolizumab. And I think the data for the IMBRAVE 150 study, they are all well known, and we have seen a high response rate, which is good and important, and which also offers the opportunity of downsizing our patients maybe to local therapy, something we can discuss later. And most importantly, we have not only seen an improvement in median PFS, which I think was okay. It was not outstanding good. I mean, with lenvatinib, we have seen a PFS of 7.4 months. So here with the IO-based combination, it was not as good as with lenvatinib, but as you all know, with lenvatinib, despite the high response rate and the good PFS, we were not able to improve median overall survival compared to sorafenib. So with atezo-bev, we have seen a clinically meaningful and statistically highly significant improvement of median overall survival benefit compared to sorafenib of 6 months, which I think is really outstanding. And based on these data, we have a clear recommendation by the international guidelines that atezo-bev should be our preferred standard of care if possible, and if there are no contraindications. And you have already mentioned one before, patients should have been checked for their varices. We need to prevent bleeding from their varices, and they should be treated accordingly. What I think is always very interesting and amazing to see the outcome in respect to response, and we have seen it many times before. Patients that respond to immunotherapies usually have a really remarkable clinical benefit, and the same story here in HCC. Patients that develop a partial or complete response with the IO-based combination have really an outstanding long-term survival. The question always is, are there any subgroups that do not benefit from immunotherapies? And I think we have now seen more and more discussions on patients with NAFLD, fatty liver disease. And we do have seen some very interesting preclinical evidence that indeed patients with a fatty liver might not respond as good to immunotherapies as patients, for example, with viral hepatitis. But when you look at now at the outcome data for not only for the IMBRAVE study, but also for the IMBRAVE study, I think it's very interesting to see that indeed the hazard ratio is not very good in the non-viral group. And this is a mixed bag. Of course, we always need to acknowledge that it's not just fatty liver, it's a mixture of different diseases, ASH, NASH, and maybe also others. Yeah, but it's very clear. Hazard ratio is only around 1 in this group of patients. But when you look at the reason why we do have such a hazard ratio, you need to look at the median overall survival. And interestingly, the median overall survival was not really significantly worse in the IO arm, but it was much better in the sorafenib arm. So I think this is something we really need to acknowledge and need to learn, that surprisingly in the past we always thought that sorafenib is highly effective in the hepatitis C group and not so much in the hepatitis B group. But when you now look at the median overall survival data, it appears that the non-viral group today also derives a benefit from sorafenib. Why? It's not really clear. And when you look at the PFS is not much better in the non-viral group with sorafenib. So I think it's really not really completely understood, and we will need more data to better understand. In summary, however, I would not recommend to base any treatment decisions on the underlying chronic liver disease at this point in time. When we talk about efficacy, of course, we also need to talk about side effects, and the side effect profile, even if it's numerically similar between atezolizumab and sorafenib, the quality and the type of side effects is clearly different between both arms. And with sorafenib, we have observed in the IMRAV study, same side effect profile as we would expect: the diarrhea, hand, foot, skin reactions, diarrhea, which is always which can be really troublesome for our patients, in contrast with atezolizumab. We also see side effects, but different side effects here, more proteinuria, hypertension. That's something we would expect. IO-related side effects, they can also be severe, but in general, and for the majority of the patient, it's better tolerable, and having a better side effect profile or a distinctive side effect profile. This also translates here in a better quality of life analysis. As you can see, that the time to deterioration, clinically meaningful deterioration, is clearly delayed in the atezolizumab compared to the sorafenib. So now, however, I would like to come back to liver function. I think that is an important topic, and today when more and more oncologists treat patients with hepatocellular carcinoma, I think it's really important to learn and think about liver function, not only because of the side effects and the problems that might arise from an advanced liver cirrhosis, such as varices and ascites and stuff like that. Also, liver function will have an impact, or has an impact, on the outcome of our patient. Yeah? The question is, how can we measure liver function? Child-Pugh is of course possible, but I think it's not too granular. We need a better marker, and I think the IB score is better suitable to measure really liver function. In contrast to Child-Pugh, we have only two markers, bilirubin and albumin. Unfortunately, it's quite difficult to calculate, so you need to use an online calculator, as has been provided by many companies. So why is it important to look at liver function? Here, when you look at the prognosis of our patients based on liver function, you can see for both Child-Pugh and IB score that patients with a better liver function clearly survive longer. But I think the most important point is, if you look on the right-hand side, within the Child-Pugh cohort, we can distinguish two groups of patients based on IB score, IB1 and IB2. And it's a 50-50 split here in the 2014 JCO paper by Philip Johnson. And importantly here, in this cohort of patients, we do have a delta in median overall survival of 10 months. Yeah, so I think this is something you need to keep in mind when you treat your patient. Just based on liver function, you can have a survival difference of 10 months in the Child-Pugh cohort. Yeah, therefore I always recommend measure IB score and not Child-Pugh score, because you will get a better information. And today IB score is also used in most clinical trials due to this important prognostic impact. So just recently, the data at ILCA, the data for the IMRAV study in respect to IB score have also been reported, and I think the data are really interesting. Yeah, when you look at the outcome, it's very clear that the outcome is better in patients with a better liver function. No surprise. When you look at how the curves separate, and if you look at the hazard ratio, I think it's also interesting. Yeah, so the efficacy of the IO-based combination appears to be much higher in patients with a good liver function. Yeah, so we always need to try to start our treatment with atezolizumab as early as possible, at a time when liver function is as good as possible, which of course sometimes is still very difficult. And we have observed a similar effect in the Keynote 240 study. Unfortunately, Unfortunately, we do not yet have data for nivolumab, but here for the keynote study and pembrolizumab, the data are currently in press in therapeutic advances in medical oncology. You can see a similar picture, better outcome in patients with a good liver function, and also the hazard ratio. It's not so clear as with atezo, but you can also see a similar trend. Median overall survival is longer in patients with a good liver function here, almost 18 months with pembrolizumab compared to 13 months with IV grade 2. So what is on the horizon? And I think we will see more combination, as mentioned at the beginning of my talk. These combinations are currently tested in the first and second line setting. I think Pembro is highly interesting in the deep trials. We have seen really very interesting efficacy in multiple tumor types, and also here, as shown in the 116 study presented by Lovett and Zhu, before we can see a high number of patients with complete responses and very nice disease control rate. So I'm really looking forward to the results of this phase 3 study. So with this, I would like to end, and I think we have now really a couple of important questions specifically in patients in intermediate stage. And here, really, we need to distinguish who will get local treatment, who gets systemic treatment. If you start with local treatment, when should we switch to systemic therapy? This is something we really need to address in the multidisciplinary tumor board. And here we need to decide together what is the next best treatment. And of course, those patients need to be identified, which can be treated with potentially curative treatment, such as resection, transplantation, and maybe even TACE or ZIRT. In general, this would not be a curative treatment, but a palliative treatment. And then patients with more advanced disease and also advanced BCHCB, multiple tumor nodules, where you cannot apply a supraselective TACE, I think we should consider systemic therapy early on. Atezo-bev is the new standard of care, but maybe we will find subgroups that are still candidates for TKIs, which could be, of course, patients before and after liver transplantation, patients with varices, and there are most likely more to come. We are now seeing high response rate with systemic therapies, with lenvatinib, atezo-bev, so we can think about downsizing, maybe not so much downstaging, but downsizing to local therapies. And as I have shown you, I think liver function is really important. Unfortunately, we do see a decline of liver function over the treatment, not only after local therapies, but also after systemic therapies. Yeah, and I think the IV score is really a nice tool we have at hand, not only to really distinguish patients with IV1 and IV2 in the TRIPUA cohort. It's an important prognostic factor, and maybe it's also a predictive factor. I think we need to look at this in more detail, but in general, we can see a better hazard ratio in patients with an IV grade 1 compared to an IV grade 2, and in general, we do see, unfortunately, a shift to IV grade 2 patients, specifically in second and further line treatment group. So with this, I would like to end, and if you have any questions, I'm looking forward to our discussion now, and you can also please send me an email if there's anything unclear. Thank you.
Thank you, Professor Vogel, for this very informative presentation, and we can have a couple of questions if there is any in the floor. As usual. Ready?
Again, I have a comment. I know it's very popular and worldwide distributed in the guidelines. Biva atezolizumab is the first line now, but I think it doesn't suit our patient in Egypt because we have a high incidence of bilharziasis, although declined nowadays, but the periportal fibrosis and portal hypertension with high incidence of esophageal varices may hinder the usage of bevacizumab in those patients.
Yeah, I completely agree. And I think we need to be really careful. I mean, first of all, we have just summarized our experience with 80 patients from 2 centers. And I think the good news is we can confirm the data in our real world cohort for patients that meet or have met the inclusion criteria of the IMbrave 150 study. However, outcome was not as good in patients that would have not met the inclusion criteria. Just as you mentioned, if you have patients with severe portal hypertension, ascites, yeah, outcome is worse, yeah, with more impaired liver function, yeah. And I think this is something that is really important and what we will need to learn in the future, and where maybe also real-world evidence will help us to have a better patient selection. I mean, the good news is we have now options. We can decide between Zenva, and Atezo-Bev, yeah, and we just need to learn now what are our best. Unfortunately, we do not have any molecular biomarkers, but maybe what are our best clinical biomarkers to apply the best possible patients in our real-world setting.
Thank you for your presentation. And my question is about patients with local disease beyond criteria for transplantation, like portal vein thrombus or shooting alpha-fetoprotein. If we are going to use TARE, do you recommend adjuvant or post-TARE use of Atezo-Bev or not?
I'm not sure whether I have completely understood the question, but the question was whether I would recommend the combination of Immuno or Atezo-Bev in combination with TARE or Y90?
Yes.
Yeah, I think that's a very interesting question. So we have just published data from immunotherapy, nivolumab in combination with TACE at ESMO. Yeah, we observed a very high response rate with the combination of TACE and nivo, which I think is promising. And Bruno Sangro has published similar data for the combination of TARE with nivolumab in the NASIR study, which I think were also interesting. Outside of clinical trials, I'm still hesitant, and we do not combine it at this point in time. I'm not really sure whether we really need this. We have ongoing phase 3 studies which evaluate the combinations. So in real world, in real clinical daily practice, we do not combine.
Thank you very much. Here we come to our next speaker, Professor Dr. Thorsten from Germany, which will update us about the new in our armamentary against metastatic gastric cancer.
I have pre-recorded the slides, so because I have a little bit problems with my PowerPoint deck at the moment, so I asked for using the slides pre-recorded. I've pre-recorded it last week, I think. Could you start the slides? Thank you very much.
Good afternoon, dear colleagues. It's an honor for me to talk at the 8th Ains of Shem University International Clinical Oncology Conference. My talk will focus update on the treatment landscape of metastatic gastric cancer. These are my disclosures. This is the molecular landscape, respectively the molecular basis for the treatment of gastric cancer or gastroesophageal junction adenocarcinoma and esophageal cancer. Based on the data of Keynote 059, Pembro was approved by the FDA as last-line monotherapy in PD-L1 positive with CPS1 or more than 1. In the cohort 2 of Keynote 59, Pembro plus chemo first line, the response rate increases even from 37 for PD-L1 negative to 73 for PD-L1 positive, the first positive results for a promising career. But for a while, data are still not so conclusive. In the keynote 062, pembro was non-inferior to chemo, but pembro or pembro plus chemo was not superior to chemo for OS and PFS. So conclusion of the data at the time point were inconclusive, and interpreting the trial was a bit difficult. We considered pembro for first-line gastric cancer, especially in patients with CPS10 and not fit enough for conventional chemotherapy, but there was no approval by the EMA. And a lot of trials were still negative for IO therapy in gastric cancer, example given the Javelin trials for avelumab, and the negative data of Keynote 061, a randomized second-line trial. But even if the trial was negative, Keynote 061 showed that example given patients with CPS 10 or more than 10, IO therapy was very effective in gastric cancer. The last line for Keynote 059 that I have already shown as well, the corresponding attraction 02 data for Nivo leads to an approval for the last line IO PD-L1 addressed therapy in several countries of the world, but not by the EMA. Attraction 04 in parallel presented at ESMO 2020 with CheckMate 649 showed a significant and extreme high PFS with 10.45 months for Nivo plus chemo and an objective response rate of 57%, but nevertheless no improvement in OS. There are several explanations for this fact. First of all, in the placebo plus chemo arm, nearly 30% of patients received IO therapy in form of Nivo or pembro after progression of disease. Secondly, at Attraction 04, nearly 50% of patients have a signal ring histology, often not the perfect candidates for IO therapy in IO first line and subsequent lines, and in addition, often not good responding to conventional subsequent lines. As just said and reflected by the hazard ratio, the diffuse type is not the perfect candidate for IO treatment according to OS and PFS. The positive data for the comparison of chemo plus minus Nivo of the CheckMate 649 were first shown at ESMO 2020. This year, an update after an additional year of follow-up of the Nivo plus chemo arm was shown at ESMO 21. In addition, the new data of the third arm with only Nivo 1 and EP 3 milligram have been shown at ESMO 21. The Nivo plus chemo combination reflected by the first arm of the trial is already approved as standard of care by FDA and now since last week by the EMA. So the update 21 of the Nivo plus chemo arm. In 2020, only the baseline characteristics of CPS5 group, as now approved by the EMA, have been shown. What is striking was the relatively low proportion of signet ring cell cancer reflected by the CPS5 and therefore the immunogenic population. In 21, baseline characteristics for all patients, including the Nivo IPI and all randomized patients, were shown. Again, also, in the overall population, the signet ring part is a bit underrepresented. 60% of all patients had a CPS5 or more than 5. OS was 14.4 months in the CPS5 cohort and 13.8 months in the overall population, with a delta of 2 to 3 months compared to chemo only. The objective response rate was 60% and therefore 50% higher than the chemo-only group in CPS5 and similar in all randomized patients. And in the MSI high, the median OS was 38.7 months with a delta of 26 months to the chemo-only group in MSI patients. So the question is, do we really need chemo for the collective as backbone? But the comparison of the MSI and MSS in the chemo-only group reflects that chemo is not detrimental for MSI high. So after warm-up of more or less already known data, we will now talk about the completely new data of the arm of Nivo plus IPI only versus chemo. In this study, the more toxic regime of Nivo 1 milligram and IPI 3 milligram was used. And maybe this is the reason why the trial was stopped early, due to twice as many serious treatment-related adverse events with Nivo plus IPI. Nevertheless, Nivo plus Ipi was not more potent than chemo alone, according to similar median OS and data in CPS5 in all randomized patients. According to PFS, Nivo plus Ipi was inferior to chemo in both groups with less than half median PFS compared to chemo only. Also, objective response rate was remarkably lower for the IO combo in all groups. What is evident? Nivo seems to be more potent than Nivo plus chemo in MSI-high gastric cancer patients, quite comparable to data in CRC MSI-high patients. Often the problematic of PD-L1 staining by the different assays is discussed because of CPS of 5 or more is represented in 60% of CheckMate 649 and Orient 16 trial example given. The big players in gastric and esophageal cancer are Pembro and Nivo, and they are using DARCO 28 8 stainer and the 22-3 assay. That's important to interpret the current landmark trials. And the current publication concludes that both assays are highly comparable to at CPS cutoffs 1, 10, and 50 in gastric cancer. In esophageal squamous cell, Nivo has already shown and already approved in second line by FDA and EMA based on Attraction 03. And also the other substances show positive data in second line, like Pembro with an FDA approval for esophageal squamous cell cancer, CPS 10, or camrelizumab or tislelizumab. The next study to discuss is CheckMate 648, also not gastric cancer, but very important. 648 was a randomized phase 3 comparing Nivo plus chemo versus Nivo 3 mg plus Ipi 1 mg versus chemo alone, consisting of 5 uses cisplatin first line, shown at ASCO 21. Primary endpoints are overall survival, PFS, centrally assessed, not in CPS, but according to TPS 1 or more than 1. Baseline criteria showed 80% of male patients and a TPS of 1 or more than 1 in half of the population. So first, the Nivo chemo arm. As shown, Nivo plus chemo improved OS and PFS and TPS 1 and more than 1 in all randomized patients But patients with TPS smaller than 1 seems not really to profit, so overall population is driven by the PD-L1 positive population. The objective response rate was doubled in both populations with the addition of Nivo to chemo. Now the chemo-free Nivo plus Ipi arm only, with the less toxic combo of Nivo 3 mg and Ipi 1 mg compared to the more toxic regime as shown in CheckMate 649. According to OS, Nivo plus Ipi was already superior to chemo in both populations, but according to PFS, only the patients with TPS 1 or more showed comparable results to chemo only. It's even so that in all randomized patients, Nivo plus Ipi was inferior to chemo only according to PFS data. This is reflected by the hazard ratios for OS that there is no real benefit for the combo of patients TPS smaller than 1. The same is reflected by the response rates. Camrelizumab was also able to show positive data in squamous cell cancer in first-line ESCOT 1 with taxane plus platinum-based quite potent backbone. Coming to Keynote 590 with squamous cell and adenoesophageal and GA junction cancer down till SIVA type 1, 70% of patients were squamous cell cancer. 50% of the overall population CPS 10 positive. Here are the positive data for all subgroups. Comparison between all randomized esophageal squamous cell cancer of 590 with the Nivo plus chemo patients of this CheckMate 648 showed quite the same data. So data between the trial are consistent. In addition, ESMO 21 sintilimab was able to show a positive results in Orient 15 trial, like the other current esophageal squamous cell cancer trials. But in the eyes of the Western world, an uncommon, very effective backbone like already used in ESCOT 1 with taxane plus platinum was used. Delta to checkpoint addition seems nevertheless the same or even better than in the already shown global studies. Orange 16 trial showed at ESMO 21 also similar data compared to checkmate 649 for sintilimab plus chemo regarding example given OS and also objective response rate in gastric and GE junction cancer. Compared to 649, no esophageal adenocarcinoma included, and again CPS5 was confirmed in this population with 60% of the population. Also, female patients seems to profit from the therapy, and with nearly 30% of patients, more women have been included than in the other global trials. Also at ESMO 21, Jupiter 06 showed positive data for toripalimab plus taxane platinum-based chemo in first-line squamous cell cancer. In Destiny Gastric 01, trastuzumab deruxtecan showed an objective response rate of 51% per investigator and 42% centrally confirmed in patients with 2 or even more lines after 100% trastuzumab pretreatment in HER2-positive population. So it has been approved by the FDA and is already part of a second-line recommendation in the NCCN guidelines. Data have now been proven for the Western population in second line, presented at ESMO 21 with a confirmed objective response rate of 30%. This is quite a milestone because besides TOGA, all other HER2 trials were negative in gastric cancer. Other Destiny trials are running, and our center is currently trying to include patients in Gastric 03 Part 2 first-line setting. And also we know tucatinib from breast cancer, a very promising substance, especially in brain mets, and is also examined in gastric cancer. Zanidatamab, a B-parotopic HER2 antibody, is currently under investigation and showed positive data at ASCO GI this year, especially in gastric and biliary tract cancer. According to Keynote 811, first interim results analysis, pembro plus trastuzumab plus chemo is already approved by FDA, caused by an objective response rate of 74% in gastric and GE junction adenocarcinoma. This year at ESMO, data from the German phase 2 were presented, the Integra trial for trastuzumab plus nivolumab, then IPI, or in the one arm or in the other arm chemo. Data for the chemo trastuzumab nivo combo were promising and confirmed indirectly Keynote 811. The combo with IPI was ineffective, as shown by the PFS of only 3.7 months. Also, margetuximab, known from breast cancer, seems to be promising, and as mentioned, zanidatamab is currently investigated in combo with chemo and checkpoint inhibition in first-line phase 3. At ASCO GI and ASCO, this year we have seen very promising data, phase 2 data for FGFR to be overexpressed in amplifying gastric cancer in first line for bemarituzumab plus Folfox. Maybe FGFR will become a new biomarker in gastric cancer like HER2. In first line, further work is made by combining chemo plus IO and TKI, like in LEAP 015 with lenvatinib. So, a lot of work has been done. Thank you very much. A discussion is open.
Any questions from audience? Okay, Dr. Thurston, as you know, in the Laurent classification of gastric adenocarcinoma, we have diffuse and intestinal type. In your practice, would you recommend to use oxaliplatin for intestinal type and cisplatin for diffuse type?
No, we are not making this decision based on, I know the data, but the problem is that this plating is not common use in the Western world now, especially in Europe. It's normally used oxaliplatin because of its less nephrotoxic problematics. And so in cisplatin, you are normally give no more than 6 cycles or something like that. And therefore, I think oxaliplatin is the most potent substance. So, and most of the Western trials are using Folfox or Carpox as a backbone, as a standard backbone. And I've last week I've discussed it as the ET committee because I'm the LKP for the zanidatamab trial. And the zanidatamab trial is using cisplatin, or the other regime is Carpox. And the ethics committee have discussed with me the cisplatin backbone because it's not commonly used Nevertheless, the according to TOGA, trastuzumab in combination with is only approved with the combination of cisplatin, but nevertheless, no one really uses it in Europe.
Okay, thank you.
The second question is, after use of nivo chemo, upon achieving your best result, do you maintain or something, or you stop treatment?
If I stop chemotherapy using the combination of the IO, this is the question. Normally, yes, we have done a lot of trials, and in the combination with nivo, or relatlimab example given, and normally we try to stop FOLFOX after 8 to 12 cycles example given, and try to use only as quite of maintenance the IO therapy.
Thank you, and thank you for your participation in the presentation. And now it is time for next speaker, Professor Dr. Ghada Rifat.
Thank you very much.
Thank you. Dr. Ghada Rifat, Professor of Clinical Oncology at Shams University. Her main interest in GI, malignancy, and gyna oncology. Dr. Ghada will present her insights about the incidence of colorectal cancer in young adults.
Thank you so much, Doctor. Thanks so much, Professor Dr. Khalid Hussein. Before everything, thanks so much for inviting me.
I have the pleasure to introduce our next speaker, our star colleague, Dr. Mohammed Yassin, one of the anchors of this symposium. Dr. Mohammed Yassin, Professor of Clinical Oncology at Shams University. He is interested in GI malignancy, and I have the pleasure to introduce him for HCC talk. What about the TKIs?
Thank you, my dear colleague, Professor Khalid Husseini, for this nice introduction. I would like Mr. Chairman, Professor Dr. Ali Azmi, and my dear colleague, Professor Dr. Ahmed Izzat. So, today I started my presentation with the role of IO in metastatic HCC, which was a practice changing. So, right now, is there still a role for standard TKI in the management of advanced HCC? Some are disclosures. As we see the milestones in the treatment of advanced HCC, we had first line sorafenib, and then the approval of regorafenib in second line, and non-inferiority trial reflect lenvatinib, and then the approval of atezolizumab as first line in 2020. So in second line, we have cabozantinib, ramucirumab, and regorafenib, and also IO, pembro, or nivo plus epi. So in first line TKI, we have sorafenib and lenvatinib, and second line, we have regorafenib if the patient is in radiological progression to sorafenib and is tolerant to sorafenib, or cabozantinib or ramucirumab, and also cabozantinib is evaluated in second line and third line. So these are the ESMO guidelines for HCC. As we all know, the atezolizumab, lenvatinib, sorafenib as first line, second line cabozantinib, regorafenib, ramucirumab, and we have other options of IO in second line. These are the updated NCCN guidelines for HCC again. So the story started in 2007 with the phase 3 SHARP trial. Patients were randomized 1-to-1 to sorafenib 400 milligram twice daily versus placebo. And the primary endpoint was overall survival and time to symptomatic progression, and secondary endpoint time to radiological progression, disease control, and safety. The median overall survival was 10.7 versus 7.9. And in the Asia Pacific trial, it was 6.5 versus 4.2. And we all know that in the Asia Pacific trial, most of the patients were HPV infected, and in the SHARP trial, HCV infected. So pooled analysis was done to identify predictive factors for sorafenib treatment. And what was seen is greater overall survival benefit in patients with HCV-related HCC. If you have patients with extrahepatic disease, it's a hazard ratio was higher for overall survival, but if no extrahepatic metastasis, hazard ratio was 0.55. If HCV infected, if we look here, if there is HCV infection, the hazard ratio has improved to be 0.47. If there is no HCV infection, it is 0.81, which means that there is a greater overall survival benefit in patients with HCV-related HCC. If the basal neutrophil to lymphocytic ratio is less than the median, the overall survival is improved and is 0.59, and if more than the median, it is 0.84. So here, as regarding the toxicity, and we all are aware of the toxicity of the sorafenib, especially hand and foot syndrome, and anorexia and diarrhea. If we look here across the trial, in the SHARP trial, the median overall survival was 10.7, but in real world and in several randomized clinical trials, there was improvement in the median overall survival with sorafenib, and maybe this is because we are getting more aware how to manage the toxicity of sorafenib. Recently, in the Checkmate 459, the overall survival was 14.7, and the IMBRAVE, it was 13.2. Then we have the approval of lenvatinib based on the non-inferiority REFLECT trial, and we have seen here that lenvatinib is non-inferior to sorafenib as regarding median overall survival. It was 13.6 versus 12.3, and this is the REFLECT trial, and patients will receive 8 milligram per kg for body weight less than 60 and 12 milligram for patients with body weight more than 60 versus sorafenib. As we see here, the patient characteristics, we had patients with mainly Child-Pugh A, only 1% of patients with Child-Pugh B, and we have patients with PCLC B, intermediate stage 22%, and the majority was PCLC C. As we see here, as regarding patient characteristics, we have looking at the etiology of chronic liver disease, either hepatitis B or C, and baseline alpha-fetoprotein less than 200 or over 200. This is a non-inferiority trial, but there is potential imbalance in the study because of the following factors. Baseline alpha-fetoprotein level, which is a prognostic factor. Hepatitis C-related liver disease, patients with hepatitis C who have treated with sorafenib do better than patients with hepatitis B. Overall survival up to 14 months. As we see, the overall survival was 13.6 versus 12.3 for sorafenib. The forest plot shows that there is trend in favoring lenvatinib, especially in patients with poor prognostic subgroup. As we see here, subgroup analysis for overall survival, extrahepatic disease, macrovascular invasion, median overall survival for lenvatinib was 11.5 versus 9.8, if no, 10 months versus 18 months. Alpha-fetoprotein, if it was more than 200, the overall survival was 10.4 versus 8.2, and less than 200, 19.5 versus 16.3. So, another post hoc analysis which was seen that patients who responded to lenvatinib had a better overall survival. So, if there is a response to lenvatinib, the overall survival has reached 22.4 months, and patients who are non-responsive, it was 11.4. The comparison median progression-free survival is 7.4 versus 3.7. Median time to tumor progression was 8.9 and 3.7, and the overall response rate was in favor of lenvatinib and was 3 times higher than sorafenib. The most adverse events were different than sorafenib. There was similar frequency of diarrhea, greater frequency of hypertension and proteinuria, and lesser frequency of hand and foot syndrome. What about dosing reduction? If we have for grade 3 hypertension or cardiac dysfunction, or grade 3 and 4 hepatotoxicity and renal dysfunction or proteinuria, we will start with 12 milligram starting dose. First dose reduction is 8 milligram, second dose reduction is 4 milligram, and third dose reduction is 4 milligram every other day. But if we started with the 8 milligram starting dose, first dose reduction is 4 milligram, second dose reduction 4 milligram, and third dose we have to discontinue our treatment. Also, lenvatinib has a delayed deterioration of role of function and general pain and diarrhea, nutrition, and body image versus patient treated with sorafenib. So, as regarding skin toxicity and overall survival in patients with HCC treated with sorafenib or lenvatinib, prospective study showed that development of dermatological adverse events within 60 days of sorafenib initiation was associated with better overall survival. And post-hoc analysis from the REFLECT, presence of hypertension, diarrhea, and proteinuria or hypothyroidism was associated with longer overall survival. So, how to choose between sorafenib and lenvatinib? Take into account, sorafenib may be preferable over lenvatinib depending on liver dysfunction. Some toxicities of lenvatinib refractory hypertension may sway a decision towards sorafenib. Patient comorbidities and susceptibility to adverse events may also guide treatment decision. Sorafenib may be preferable in patients with HCV etiology. Subgroup analysis suggests lenvatinib could work better in patients with very aggressive disease. Higher tumor response rate with lenvatinib was 3 times higher than sorafenib. If we're looking at higher tumor response, we have to choose lenvatinib. For patients that don't tolerate sorafenib, consider switching to lenvatinib rather than moving to second-line treatment. If we look at the exclusion criteria of the EMBRAVE study, atezolizumab is absolutely contraindicated in post-transplant setting, is relatively contraindicated in autoimmune disorders, requires precaution in patients with varices and bleeding risk and hypertension, and requires some consideration in non-viral etiology. So those are the patients who can benefit from sorafenib and lenvatinib. So the standard of care according to the ESMO guidelines before the approval of the EMBRAVE 150 atezolizumab was sorafenib and lenvatinib, which showed non-inferiority for patients compared with sorafenib, and for treatment in patients with advanced HCC without main portal vein invasion, clear bile duct invasion, and less than 50% of tumor to total liver volume occupancy. So how to choose the second line? Deciding on a checkpoint, patient did not achieve a significant benefit with a TKI, patient tolerated the TKI poorly. Deciding on a TKI, patient tolerated TKI well. Regorafenib in particular has been studied in patients who tolerated sorafenib. Cabozantinib has a different mechanism of action, and ramucirumab for patients with alpha-fetoprotein more than 400. So there are no data comparing checkpoint inhibitors versus TKI in second line. Many factors must be taken into consideration. Risk of adverse events. Checkpoint inhibitors may be better tolerated, but include immune-related adverse events, especially immune-mediated hepatitis. Immune checkpoint inhibitors have durable response. Sequence of TKI matters. This is a comparison between second-line TKIs. We have the resource regorafenib trial, Celestial, cabozantinib in second and third line, and we have the reach to ramucirumab in second line for patients with alpha-fetoprotein more than 400. Sorafenib and regorafenib are identical, and the only difference between sorafenib and regorafenib is in the fluorine molecule. And regorafenib metabolites M2 and M5 have continued antineoplastic effect during first week of washout period. As we all know, regorafenib is taken 160 milligram 3 weeks on, 1 week off. This is a resource trial, and one of the important in this trial is that patient has to be tolerated sorafenib at least 400 milligram per day for the last 20 days of the last 28 of treatment. Patients are randomized to regorafenib 2:1 versus placebo. Remember, all the trials in second line are versus placebo. The overall survival was 10.6 versus 7.8. And a very important issue is the sequence of sorafenib and regorafenib. And there was the median overall survival from starting of sorafenib for patients who tolerated sorafenib and then progressed radiological and received regorafenib. It was this sequence had achieved an overall survival of 26 months. This is the efficacy data. Overall survival 10.6, 7.8, median progression 3.1 versus 1.5. Subgroup analysis, there was no difference in macrovascular invasion and the region and alpha-protein level. As we all know, regorafenib treatment adverse events also had the food syndrome, diarrhea, and hypertension. And here we see the sequence of sorafenib and regorafenib has achieved an overall survival of 26 months, and sorafenib and placebo 19.2. This is exploratory analysis. Development of hand-foot syndrome with Stivarga or regorafenib has been associated with a prolonged overall survival. So real-world studies show a consistent overall survival benefit with regorafenib. In the resource trial, it was 10.6. But in some trials, it has reached 25.3 months overall survival, especially in the Asian population, although we know they are different than the rest of the world. So, sorafenib and regorafenib have been evaluated in patients not typically enrolled in randomized clinical trials. Sorafenib and regorafenib have been evaluated in patients with Child-Pugh class B and C, although they have been associated with a higher frequency of adverse events and shorter survival than in patients with Child-Pugh class A liver function. Regorafenib demonstrated similar efficacy and safety to resource in 28 patients with recurrent HCC after transplantation with no case of rejection. Sorafenib and regorafenib have been evaluated in patients with ACOG performance more than 2, but this was associated with shorter survival than those with ACOG 0 to 1. Regorafenib has been evaluated in patients who are intolerant to first-line sorafenib, which was a main inclusion criteria in the resource trial, and demonstrated similar efficacy and safety to the resource trial, which means we need real-world data, and real-world data are different than the specifics patient in the randomized clinical trial. Celestial trial, cabozantinib, which is different TKI. Patients are randomized 2 to 1 cabozantinib 60 milligram once daily versus placebo, and this was for patients progressed on sorafenib or for patients in third-line treatment. Overall survival was 10.2 versus 8 for placebo, and progression-free survival was 5.2 and 1.9. Here, cabozantinib in second-line HCC post-sorafenib, there was improvement overall survival 11.3 versus 7.2, and median progression-free survival was 5.5 versus 1.9. Also, overall survival and progression-free survival forest plot has showed that cabozantinib works better in high aggressive tumors, especially extrahepatic and microvascular invasion, and there was a trend favoring HPV virology infection. Subgroups of patients who only received systemic therapy was sorafenib. Median overall survival was improved and it was 11.3 months. So what we have learned from the exploratory analysis of the Celestial trial, overall survival and progression prolonged irrespective of age, and also there was improvement in HPV etiology, and progression overall survival and progression improved across a range of baseline alpha-fetoprotein, and also irrespective of prior tests, and also overall survival improved in patients subgroup defined by extent of disease burden. So, used in practice, it can be used in first line or in second line. And how to choose in first line, so it can be used in second line and third line. How to use in second line versus regorafenib, choice is not easy based on subgroup analysis. Both are eligible options. These are the toxicities of Celestial trial, grades 3 and 4. Palmar hand and foot syndrome, hypertension, AST increase. And also there was improvement in the quality of life, health-related quality of life from the Celestial trial with patients who have received cabozantinib. And this is a REACH trial. REACH 1 was a negative trial, but the post hoc analysis or pooled analysis of patients with alpha-fetoprotein over 400 showed a trend for patients, improvement for patients with alpha-fetoprotein more than 400. So as we see from the REACH 2, median overall survival was 8.5 versus 7.3 with a hazard ratio of 0.7. And the pooled analysis showed a median overall survival of 8.1 versus 5 months for patients who received ramucirumab for patients with alpha-fetoprotein more than 400. These are the adverse events of ramucirumab. It's typical with an anti-VEGF, hypertension, peripheral edema, ascites, bleeding, and black box warning was gastrointestinal perforation, hemorrhage, and impaired wound healing. So the conclusion, actually ramucirumab is not a TKI, it is a monoclonal antibody which specifically inhibits VEGF-R2. Safety profile is distinct from other TKIs. Ramucirumab is a monoclonal antibody. Hypertension and hyponatremia don't exhibit other TKI-related side effects which may provide a clinical advantage for patient. So in second line, if we have a frail patient and alpha-fetoprotein more than 400, ramucirumab is a good option. So choice of agents, many factors to consider, inclusion criteria in randomized clinical trial. Patients intolerant to sorafenib were excluded from the resource trial. Patients were treated with cabozantinib in the third line setting in the Celestial trial. Adult patients enrolled in the resource and Celestial trial. Patients more than 65 and less than 65 had similar benefit. And we have to look at the etiology of the treatment. TKI in clinical practice, majority of patients with advanced HCC can be treated safely with TKI. Some population which use TKI may be inappropriate, worsen clinical condition without well-preserved liver function, and patients with vascular disease. TKI adverse events, general fatigue, asthenia, hypertension, skin hand and foot syndrome, GIT, diarrhea, laboratory neutropenia, elevated liver enzymes. Dose adjustment is very important. Rather than discontinuing a novel TKI, clinicians should be consider reducing the dose in order to improve tolerability and manage adverse events when necessary. Drug activity is not lost with a reduction in TKI dose. Potential improvement in survival since patient will remain on the drug. Key principles of effective toxicity management: engage an MDT team, obtain a baseline before initiating therapy, including frequency of diarrhea, blood pressure, observe hand and foot syndrome. Engage primary care, think about dose reduction. So this is algorithm for systemic treatment sequencing for advanced HCC. First line we have atezolizumab, then lenvatinib, sorafenib, and in third line we can move the second line treatment like cabozantinib, regorafenib, and ramucirumab. While if we use lenvatinib or sorafenib, we have, especially after sorafenib, cabozantinib, regorafenib, and ramucirumab in third line option. So summary: various TKI and immune therapy treatment options available for both the first and subsequent lines. Data on subsequent lines limited to treatment following sorafenib. Treatment selection challenging, need to balance toxicity, quality of life, comorbidities, and special population. And thank you for your attention.
Thank you, Professor Muhammad, for this rapid wrapping of TKIs in HCC. And now it is time for questions.
Dr. Muhammad, I have an observation, and I think many of my colleagues may share me the same observation, that the results of various TKIs in treating patients, Egyptian patients with HC, is much more inferior than the results in the international literature. I think the reason for that that the pivotal trials like SHARP trial or Asian Pacific trials didn't enroll patients from the Middle East area. What's your opinion?
Yes, I totally agree, and we are working in the same department. We are seeing the same results. Unfortunately, the results of the SHARP trial and the Asia Pacific, and even the combination of IO versus sorafenib trials in BRAVE 100 has resulted in the median overall survival which have reached more than 14 months with sorafenib. Unfortunately, in our patient, we don't see such results of improvement of overall survival and progression-free survival, which means that our patients are different in the cirrhotic, our cirrhotic HCC is different than the rest of the world. And unfortunately, none of our type of patients are enrolled in the randomized clinical trials, which has yielded these results. I totally agree. Yes.
Dr. Yassine, I think Dr. Mark Peters have a question for you.
Okay.
Dr. Mark?
Yeah, thank you very much for
Hello,
this.
Professor Mark, my dear friend.
I have a question.
Yes.
You showed the algorithm, and it's for sure the algorithm that we all use. You start with atezo-bev, and then you go to a TKI. But how strong is the evidence in the literature that this algorithm is really based on evidence?
There is no data on that. And I've asked this question many times to Professor Richard Finn, who was the PI of the BRAVE 150. What to do after progression of atezo-bev? There is no clear answer, and there are no trials ongoing now to answer the question. So it is wise to use drugs which have not been used in first line, like sorafenib and lenvatinib, to move them to second line, and then to move patients, drugs of second line to third line. Although these drugs are only tested after progression on sorafenib, and these drugs are in second line and third line were tested versus placebo. There is no direct comparison between TKIs and IO in second line. So I've asked him, will there be trials for second line and third line after atezo-bev? They have told me this is a waste of resources, and they are concerned about financial issues to do such trials, and it is better to do to give Atezo-Beaver in first line and second line, what was not given in first line to be given in second line and then third line.
Okay, thank you very much.
Thank you, my dear friend, Professor Mark Peters. Thank you. Bye-bye.
Bye.
Professor Yasir, I have a question for you. The combination of Atezo-Beaver
Beaver.
for us. I think our patients, as we just mentioned, the cirrhotic patient and the financial burden patients, I think the tolerability differs from the worldwide
Yes.
patients.
Yes.
What's your opinion?
Yes, I totally agree. So this is the scope of my presentation today. There is still a role for TKIs, and we have to look very carefully at the selection criteria of the Atezo-Beaver EMBRAVE 150 trial, because we have a different HCC cirrhotic patients with more patients with varices, and this is a top exclusion criteria for the EMBRAVE 150. Yes.
Right, thank you, Professor
Thank you.
Yassin, for your very informative presentation. And Dr. Khaled Husseini has a question.
Yes.
I feel we are talking about, even you show us in the paradigm of treatment, we are talking about TKIs, talking about Atezo-Beaver, something beyond our capabilities in our daily work, in our real daily work.
You mean financially?
I mean financially.
Yes.
So I have two comments. Do you recommend to be not far away from the ideal life, and not to stand still in our daily work with using chemotherapy that is not standard? Do you feel we have to take a step forward to enhance our use of chemotherapy to reach a data touching these published data?
Definitely, we need our own data based on our patient's profile. And as you have seen in the NCCN guidelines, in first line, FOLFOX is approved in China. We know that the condition is different between Europe and rest of the world and the United States, where is availability for immunotherapy and targeted therapy. But in China, one of the main standard of treatment is FOLFOX. Based on what you are saying, we need also our own data, and we have to explore more chemotherapy regimens to have our own data. Although it is category 2B, but it is widely used in China patients. And we have our unique patient characteristics which need to be explored through different types of treatment. I totally agree, yes.
Second point, with limited resources, if we can do a good job, if we can have resources, do you like to expand the use of such treatments, or to direct it to a screening program? Especially, we have a database now with the national campaign against the HCV.
Yes.
You can direct, or you can suggest to
Yeah.
direct these resources for
Yes.
screening of HCV.
Yes, I totally agree. Screening is a very important issue, and we have, as Professor Ali has said and Professor Ahmed Aizad has said before, we have a unique patient characteristics. We have a different HCC cirrhotic patient characteristics. That's why we have different results than the real world randomized clinical trials, and we need to explore this issue through screening and better profiling our patients. Yes, I totally agree. Thank you, Professor Khaled, for your insights. Thank you.
Thank you, Professor Muhammad. And we move to the next speaker.
Professor Arnold Fogel.